So my name is Allen Lim. I'm a gastroenterologist at John Flynn, and I'll just like to provide an update on colonoscopy screening and surveillance. So colorectal cancer is the third most common cancer in Australians. 1 in 21 Australians will develop colon cancer in their lifetime. It's the second most common cause of cancer death after lung cancer, and about 90 Australians die from bowel cancer every week. Interestingly, 80 to 85% will not have a family history of bowel cancer. And next, we'll go on some definitions. Screening. Screening refers to a test for the presence of condition in someone who does not have symptoms. Is obviously aimed at detecting a malignant or pre-malignant disease at an early and favorable prognostic stage. Surveillance refers to the actions in monitoring a known condition. This demonstrates that the incidence of bowel cancer increases very dramatically after the age of 50. However, there's increasing data recently that the incidence of bowel cancer prior to the age of 50 is rising. And in fact, in some countries, including the US, there's been a recommendation to start screening from the age of 40 to 45. In fact, if you ask all the gastros and the colorectal surgeons, they've all already had their colonoscopies before 45. All right. I'll just like to touch upon the common types of polyps that we may find on colonoscopy, and they do have an implication on the surveillance intervals. So almost all colorectal cancers are derived from the two main types of polyps, the adenomatous polyps and the sessile serrated lesions. Of the adenomas, the tubular adenoma is the most common one, but tubular villus adenomas and villus adenomas, although less common, they do confer an increased risk of malignant transformation. Sessile serrated lesions, we are becoming more aware of these, as we understand that these are also associated with an accelerated malignant transformation. The main morphological types of sessile serrated lesions include sessile serrated adenomas, traditional serrated adenomas, and hyperplastic polyps that are proximal to the sigmoid colon. Hyperplastic polyps in the sigmoid colon and the rectum are not thought to be associated with increased risk of bowel cancer. Okay, just a few photos of some polyps that we may encounter. So on the top right, you've got a sessile tubular adenoma, and on the bottom left, there's the pedunculated tubulovillus adenoma. Now on the right, there's a sessile serrated lesion. If you look at the uncolored one, they can actually be very difficult to detect, particularly if the bowel preparation is not perfect. And they're frequently very flat, and they have a little mucus cap that gives it a cloudy appearance, and that's how we've learned to find them. Otherwise, they can be very hard to see. This graph shows that survival from colon cancer obviously is affected by the early stage of detection. So obviously, the earlier stage that we detect cancer, the better the outcome. Touching on population screening, most GPs nowadays would be familiar with the fecal occult blood testing. The one that's currently in use is the immunochemical test. So this is very specific for human hemoglobin and is not affected by diet or medication. Historically, there was another test called the Guaiac test, and this relies on oxidation and is affected by diet, medication, and non-human hemoglobin. Population screening using fecal occult blood testing is shown to detect cancers at an earlier stage and improve survival. There are, however, obviously some limitations. It will not detect non-bleeding polyps or cancers, and frequently we do get false positives from hemorrhoids, angiodysplasia, or blood originating from the upper GI tract. with the National Bowel Cancer Screening Program, this has been in place for the last 7 years. Australians aged between 50 to 74 are invited to perform fecal occult blood tests at their local lab. The participation rate is usually about 40 to 48%. Out of these, about 7% will return positive, and out of that 7%, 1 in 30 are found to have colorectal cancer. And that sort of roughly translates to about 900 every quarter. In 2019, Medicare introduced new surveillance criteria and restrictions. And this actually continues to evolve over the recent couple of years, which is why I think many GPs will find why is there a lot of variation and alterations to the patients being called for surveillance colonoscopy. Now, a patient will qualify to have a colonoscopy if they've got a positive fecal occult blood test, they have symptoms or new onset anemia, iron deficiency, diagnostic imaging showing abnormality of the colon, such as a CT scan showing abnormalities, or surveillance after having surgery for colorectal cancer. There's also provision for to repeat a colonoscopy if the bowel preparation is poor, and also obviously to guide in treatment of inflammatory bowel disease, as the target for treatment nowadays is to actually see complete disappearance of the inflammation in the colon rather than just symptomatic remission. Okay, and patients are eligible for a 5-year recall if they have a history of 1 to 4 adenomas, small in size, no high-risk features. 1 to 2 sessile serrated lesions, small in size, no high-risk features. Family history in terms of risk, Medicare defines this as having 1 first-degree relative less than 55 years old, or 2 first-degree relatives of any age, or 1 first-degree relative with 2 second-degree relatives. And for 3-year recall, there's history of any sort of polyp more than 10 millimeters, history of an adenoma with high-risk features, history of 5 to 9 adenomas that do not have any high-risk features, history of sessile serrated lesions with dysplasia, history of more than 3 sessile serrated lesions without high-risk features, history of 1 to 2 serrated adenomas of any size. Now, so far, can any of you remember this? No. So obviously, it's becoming quite complex. And I mean, it's easy for me because I cheat and I have it on my laptop to refer to. Okay. So this slide just covers some of the situations where close surveillance are indicated, and in particular the piecemeal resection or incomplete resection of a large polyp. There's a 20. So if we have to remove a very big polyp in a few pieces, there's a 20% chance of regrowth. So that in patients like this, we would call them back for a checkup of the polypectomy site, usually 3 to 6 months afterwards. And with annual colonoscopies, that's mostly with patients who have a known or suspected familial or genetic conditions, such as familial adenomatous polyposis or HNPCC. So just an important note, patients with symptoms should not be screened, they should be investigated. Symptoms of colorectal cancer, this would be very familiar to most doctors. The so-called red flag signs, such as rectal bleeding, unexplained change in bowel habit, new onset iron deficiency and anemia, new onset unexplained abdominal pain, and unexplained weight loss. So in summary, fecal occult blood testing is very useful for population screening in asymptomatic individuals that are at slightly above average risk. Patients who actually have symptoms should be investigated. Colonoscopy is the gold standard for diagnosis of colon cancer, and colon cancer surveillance is tailored to individual risk. So at this stage, I would like to invite any questions or items that you want to discuss.
there a notion of having an initial colonoscopy in the screening program?
So there isn't. So I guess if we go back to the slide where there is. So this is the indications that we are allowed to perform initial screening colonoscopy. But if a patient has some symptoms, even if it's transient, that would be enough. Okay.
In one of your slides, you said that the participation rate was it 42 to 48%. Is there any strategies you might have when you see patients to increase that participation with the FOBT?
So, I mean, this is administered by the government at a population basis. There will always be people who choose not to, and also probably a proportion of people might have had a recent colonoscopy, and therefore they do not need to do the fecal occult blood test.
We've got Norman Swan plug in on TV now. Try and get the message across.
Okay, well, I guess then in that case, we'll move on to the next topic. All right, so the second part of my talk will be in relation to capsule endoscopy. So what is capsule endoscopy? It's a pill-sized capsule that contains a wireless camera, a light source, and a battery. This allows a non-invasive examination of the GI tract, and it can be swallowed or delivered endoscopically. It was first developed by Given Imaging, but there are other companies who have joined the race. Capsule endoscopy, with the Given capsules, there are a number of different ones, but the only one that is available in Australia under Medicare is the PillCam small bowel. The PillCam colon, although sounds attractive, is completely the opposite. Okay, in order to perform the PillCam colon, the patient has to swallow the capsule per orally and then continually take bowel preparation to flush the capsule through the small bowel so that it can reach the colon with enough battery left to make a recording. And furthermore, it's interesting to know that the capsule doesn't travel in a linear fashion. It just goes back and forth, back and forth, back and forth, tumbling here and there, and most of the time you don't even know where you are. And I think the bowel preparation is 3 times worse than having bowel preparation for colonoscopy. So the last capsule there is the PillCam patency. This is a dissolvable capsule, and it's radio opaque, so you can see it on X-ray. So we would use this to test if the real PillCam will pass through the small bowel. These are in situations where patients whom we suspect might have a stricture or a narrowing that may prevent, that may cause an obstruction. So we basically administer this as a test, and if it does get stuck, we just wait 72 hours as it will dissolve and the obstruction will pass. All right, so there are really only 2 indications that is paid for by Medicare for capsule endoscopy. The first is the investigation of obscure GI bleeding, where there's recurrent persistent bleeding causing anemia, so it must cause anemia or very active bleeding. Gastroscopy and colonoscopy needs to have been done recently where it's not identified a source. The second indication paid for by Medicare is the small bowel surveillance of patients with Peutz-Jeghers syndrome. These are patients who have a genetic abnormality where they form hematomatous polyps that have a that has risk of malignant transformation. There are obviously other uses for the capsule endoscopy, but unfortunately not paid for by Medicare. That can include an investigation and staging of small bowel Crohn's disease. In fact, this is the best method. Investigation of unexplained small bowel symptoms or abnormalities seen in CT or MRI. Unfortunately, this is limited by the high cost. It's about $2,000. Now, RIS is actually very safe. It can be used in patients with pacemakers, implanted defibrillators. There are obviously a small percentage of patients who are unable to swallow the capsule. These are mainly patients with pre-existing swallowing disorders, strokes, neurological disorder, or previous strictures or damage to the upper GI tract. So in situations like this, we can actually deploy the pill cam endoscopically. So there's a device that allows us to push it down into the small bowel. There's a small risk of aspiration of the capsule. Obviously, this is again in patients with disordered swallowing. I've never had to perform a Heimlich procedure for any patient encountering this. 1 in 100,000, there may be 1 in 100, there may be a risk of capsule retention, and rarely that can cause bowel obstruction. Therefore, in patients considered high risk, I would perform the patency capsule first. The capsule is not perfect, but it's the best modality that we have to examine the entire small bowel. Its limitation is because it's a passive recording device. We have no control on how it travels, where it looks, and there's no way you can remove any debris or fluid that's blocking your view. So it's estimated that we probably will achieve about 70 to 80% of mucosal views. It has a significant role in diagnosis and also help guiding an interventional procedure with balloon enteroscopy. Just quickly, balloon enteroscopy is basically an extra long endoscope that has a balloon at the end of it. It helps to drag the small bowel onto the scope because there is 20 feet of small bowel. So in order to go as far as possible, you don't really have a scope long enough that you can control. So you use the balloon to drag the scope down as far as you can. Now, there's some preparation that are required for capsule endoscopy. It's not as stringent as having a colonoscopy. Patients can eat and drink as per normal up until a normal lunch the day before the procedure. Following lunch, they will go on to a clear fluid diet and they will fast from midnight. This is how the setup is. The patients will wear a sensor belt around their waist on the outside of the clothes, and they wear a sling bag that contains the data recorder. So the data recorder receives the wireless pictures from the pill cam and records it, and then we replay it on the computer almost like a video, although it's basically individual pictures. Now, the most common reason for capsule endoscopy obviously is to investigate occult GI bleeding and iron deficiency. The most common finding is nothing. 50% of patients with iron deficiency you can't find a reason for it. And with what we do find, the most common are small bowel angiodysplasia. So I've got 3 pictures there. The one on the left shows an actively oozing angiodysplasia, and the other 2 shows what the angiodysplasia looks like. Angiodysplasias are basically dilated capillaries that grow into the mucosa of the small bowel, or in fact, they can grow anywhere in the GI tract where there should not be any blood vessels. They do create a problem because they are recurrent and they cannot be fully eradicated. So intervention is usually, even if we detect them, intervention is usually only performed if there is heavy bleeding. Other things that we may find include small bowel tumors. Gastrointestinal stromal tumors are one of the more common ones, and other things include small bowel lymphoma. Okay, so now I got a video, and it shows a gastrointestinal stromal tumor. Now don't blink, you might miss it. Okay, imagine if you have to sit there for 1.5 hours watching the whole video. Well, I hope it works.
Oh, yeah. Wow.
Okay, so the classical appearance of a GIST is it's a neuroendocrine tumor. It grows from the submucosal layers, so it pushes up the lining of the small bowel, and because it's malignant, eventually it likes to erode through the top of the of the tumor, so creating an ulcer, like I guess like icing on top of a round cake. Okay, so other things we might see: Crohn's disease with the serpiginous ulcers, parasites, and I'll end my talk with a nice video of a parasite. Okay, so this was recorded in a middle-aged man who started to develop recurrent iron deficiency and intermittent melena after returning from a trip to Cambodia. Now he recalls accidentally swallowing some contaminated water from the Mekong River during a boat ride.
Oh, right. Oh, there you go. Ooh. Right thing.
You can almost see like a mouth there. You want to see that again?
Yeah.
All right, so that concludes my talk on capsule endoscopy.
I had a patient going to have an endoscopy with Ben Allen just last week.
Mhm.
Had to cancel because when he read the instructions on the P-prep, is it P-prep they use?
Yes.
Pico prep, it said not with severe renal failure, and he had severe renal failure, so he had to cancel, unfortunately.
Okay.
Yeah.
So I mean, you don't always need to use the bowel prep for, this is for capsule, I presume?
Yeah.
So for capsule, but we frequently do give one dose of bowel preparation. If they can't take pico prep or pico select, they can always take one of the others which are more volume based. So things like Bobby prep or can be used.
Oh,
Yeah.
that's good, I'll get there. Yeah.
Okay, but that gives a little bit of a washout and better views, usually towards the end of the small bowel in the ileum. Yeah, that little bit of washout seems to make an extra difference.
Dr. Lim, just with all the changes to when you're allowed to do repeat scopes and things, how does it integrate with fecal occult blood testing? Because you know how you get an invitation at 50, 55, 60. We've sort of been doing every 2 years of fecal occult blood testing, thinking that that's sort of more recommended, even though the screening program's every 5 years. But in someone who's having to have every 5-year colonoscopy anyway, I tell them there's no point doing an FOB.
Yes, that is correct. Okay. So unfortunately, this is all part of Medicare's guidelines and restrictions. So that's why we end up with the fecal occult blood testing. There's no not clear. The reality is that the situation is not entirely clear. So we do the best that we can, balance against what Medicare wants us to do. Obviously, what you've mentioned is absolutely correct. If the patients have been on regular surveillance, there's no need for them to do the FOBT testing. Okay, so if they're 5 yearly and they have no symptoms in between, then there is no need to do it because they are already being checked.
Sometimes they're coming back now. It used to always be, come back in 5 years, come back in 5 years. Now it seems to be come back in 5 years, but do FOB every 2 years. And I sort of think, well, why? Do I really need to do that as well?
Yeah, I think that because it's not a clear guideline, so you may find that different practitioners may do different things. Yeah. So for me, if a patient with me on regular colonoscopy surveillance, then I don't usually suggest doing the FOBTs. Obviously, if patients have symptoms in between, they should be investigated. In my practice, I only suggest the FOBT testing if I've discharged the patient based on the criteria that I've shown, that say they come back and then there's no findings on a colonoscopy that was done 5 years after a previous polyp. Then I say, oh well, from here on, we don't need to routinely do colonoscopies. Make sure your doctor does a FOBT once every 2 years. But I appreciate there's a lot of variation because it's not clear, and Medicare has have gastroenterologists and other endoscopies, one arm tied behind their back.
Thank you.
Okay, thank you.
Thank you.